welcome everybody, old friends and new friends, to our Chatting With series. And I'm just going to go through the plan of the evening for everybody and some housekeeping, and then I'm going to hand over to Emma. So we're going to share a little bit of information about the charity, then hand over to our speakers for the evening, who are going to give us a chat about pain. And then we're going to do a Q&A session and a roundup at the end. So just a little bit of housekeeping. You're all going to be on mute during the talk. We are recording the session, so it will be uploaded to our YouTube channel. So for any of your friends that wanted to come but couldn't come, you can feed this on to them afterwards. Any questions that you have during the evening, what we would recommend, that's worked really well before, is to put them in the chat, and then I will take any questions down. Now, if you want to remain anonymous, just make them directly to me. If you're not bothered about everyone else knowing your question, then just put it to everyone, and that's fine. I hope you enjoy the evening, and I'm going to hand over to Emma.
Thank you. Sorry. Hi. So I'm going to use this opportunity to just tell you a little bit about the charity. Adult Cerebral Palsy Hub was established to create a home for the 130,000 adults living with cerebral palsy in the UK. Our vision is all about empowering adults with cerebral palsy to live their best life. We want all adults with cerebral palsy to have access to bespoke and integrated medical services to meet their changing needs. We believe that cerebral palsy shouldn't be a barrier to living a full and active life, and we want adults with cerebral palsy to remain active members of society despite their condition and changing needs. Our hope is that through Adult Cerebral Palsy Hub, we can create, foster and give a much needed voice to adults living with cerebral palsy and raise the profile of our large but currently underrepresented community. Our activities to date are focused around 3 pillars. The first, community support, building an engaged community that can support itself. We want to build a community, and by providing a framework, we hope to give an opportunity for everyone to come together and support each other. We have seen our support groups grow during the pandemic, and we now run 3 different weekly groups, providing an opportunity for people to make friends, share ideas, and importantly, reach out to others for support. Pillar 2, self-care, helping our community to manage and be the experts in their own condition. We know that services for adults today are not ideal. However, we really believe there are things that can be done to help people to better manage their own condition. An example of this is our movement challenge. We are strong advocates for promoting activity and encouraging our community to keep moving, as we know that this is one of the best ways to support mobility. We have seen firsthand during our first movement challenge where 15 gallant individuals trusted us to support them to become more active, even during the constraints of lockdown. They've all reported that their physical and mental health have benefited from this. Thirdly, the patient voice, giving a voice to the community. Our final pillar is about creating a community so that we can come together and form a movement for change. We all agree that the understanding of CP today as a lifelong condition that affects adults too is limited, both amongst ourselves in the community and amongst the medical and researchers. I'm pleased to say that we're beginning to see that that narrative is changing, and now we understand what the needs of adults living with CP are. We welcome the new NICE quality standards as evidence of this. However, we also know that services for adults with CP are sporadic at best, and that this needs to change to come in line with these new guidelines. We believe that by sharing experiences and demonstrating how practice can be done differently, we can galvanise support and begin to change what people imagine is possible for our community. It is only by using this strong community voice that we believe that we can affect change. Understanding how to help yourself is empowering, and we endeavour to share as much information that we learn with the community through our website and during evenings like this. And this is how our Chatting With series began. We realised that particularly now it is difficult to reach out to professionals to find answers, and so we wanted to bring the professionals to you. And that turns me to tonight. We recognise that pain is a big issue for our community, and that many of us do not have regular access to the medical and rehab support to get the answers that we so desire. This is why we're so pleased to welcome Dr Charlie Fairhurst tonight, along with physiotherapist Susie Turner, who with their wealth of experience can provide some answers to the questions that you've been wanting to ask. Dr Charlie Fairhurst is Head of Children's Neurosciences at the Evalina Hospital in London and comes with many years of experience treating children and young adults with cerebral palsy. Dr Fairhurst works closely with the orthopaedic team and gait analysis lab and is highly experienced in botulinum toxin. His focus is always on function, comfort and care. And Susie Turner is Deputy Clinical Lead Paediatric Physiotherapist at the Evelina Hospital. She's currently involved in a project with NICE, focusing on transition and cerebral palsy. And with that, I'm pleased to be able to hand over to them to lead the rest of the evening.
Hello, I'm just going to share my screen first off. Give us a second. Charlie, old man, IT, fairly dodgy. So give us a second. There we go. Okay, so let's get going. There we are. Thank you very much, Emma. It's a huge pleasure for me and Super Suze.
And it is a huge pleasure for me too, because I know how important the work is that you're doing to support the community. So we're really pleased to be here. Thank you.
Thrilled. And something that Susie and I, we work very closely together. There is the boundaries are at best very, very blurred. Susie is a world expert on saliva control and constipation, as much as I've learned just about everything that I know about movement challenges from the fabulous physios. So we really, I know lots of people say we work in a great team, but actually we are, a unit, frankly, and do things fairly interchangeably in trying to support the young people that we look after. And when we say young adults that we look after, certainly the oldest patient that I have on my list is 86. So young adults is a little bit of a stretch. It's an utter joy to speak to you. I'm going to start off initially, and we'll interchange. We're very relaxed. We're just going to give you about sort of half an hour with a few slides just to sort of get some stuff down. But the most important thing, quite frankly, is a question and answer. And Susie, if I've missed anything on the slide, I'm sure will come in and give her opinion, and ditto exactly the same. So this is very, very relaxed, and we've really just got these slides as a memoir. So I've been a consultant now for close on 25 years, and Susie's been with me for
12 years.
So half that time, just about, and she survived it. And really, the whole push of how we do things is listening to the children, listening to the families, listening to the young people, as Emma said, with regards to the main challenges. And one of the big things that I've tried to put on the clinical agenda over the last 20 years is our really poor recognition and the really poor management of pain in cerebral palsy. So we're just going to take you over a few slides as to why we think it's so important. I will try and give you some very basic introduction to 2.5 terms worth of medical school on what pain pathways are, what the different types of pain are, why you feel them, why they happen, and then we'll spend a little time giving you some sort of generalities on management support and thinking about doctory things and thinking about therapy things and how we can prevent them. Does that sort of tie in with your thought process, Suze?
Yep, perfect. Go for it.
Yay. Okay, great stuff. And I'm highly IT here. I've got one computer over here and one computer over here. So if I hit the wrong button, we'll work it out. So this is something. So 25 years ago, when I started as a consultant, one of the things that I first noticed was that a variety of the multidisciplinary teams that I was involved with across the South Thames region were dealing with young people with cerebral palsy and having annual reviews, and that was all fantastic and that was great. But what was happening, that those annual reviews were identical when the individual was 3 and when they were 30. And the team around the individual was going, oh, we've tried really hard doing X, Y, and Z, and we haven't managed to succeed this year, and next year we'll have a go at doing A, B, and C. And it's exactly the same when they were 3 and 30, and nobody was reflecting on why things weren't working, why the services weren't moving forward to support the individual. And so I sort of created this thing called a hierarchy of clinical needs, and we're only focusing on the center, the core need. I don't know about you, but if I've got toothache, if I've cut my foot and I'm in pain, I can't do anything. That's it. You know, there's no point in asking me to go and do a clinic, because all my body can concentrate on is that pain and discomfort. And part and parcel of it is the recognition as well that pain is not just a physical thing, but pain is very much and very strongly an emotional thing. So there is a strong psychological element of pain, in that if you don't feel safe, you're going to feel pain an awful lot more. So when you're dealing with pain and discomfort, you have to recognize it, that it's the core of everything. There's no point worrying about epilepsy if pain is there. There is no point worrying about your nutrition if pain is there. There is no point worrying about your communication system if pain is there, because actually until you've got that sorted out, everything else is secondary. Okay. Anything else you wanted to add on that, Suze, or am I prattling on quite merrily?
Fine.
Okay, I shall carry on then. So this is the sort of technical slide. I apologize for this, guys, but again, I'll try and make this as simple as possible. So how do we feel pain? We have a variety of specific receptors in our skin, in our muscles and tendons, in our body parts, that feed in to the nervous system in a really complex sort of interdigitated pathway, ping up to the brain, to areas of the brain that we call, and here's a big long word, nociceptive centers, that help us recognize, oh my God, that's painful. And normally what happens in those situations is you get responses to it. So we have the sensation of pain, we have those pain pathways, we have what's going on up here in the brain in terms of how it recognizes it. But also, as I said before, the emotional aspects are really important about how we can adapt, how we can manage our own pain and discomfort. So that's half the problem. And it's half the problem with all the lovely people that I look after with cerebral palsy, whether it's highly functional young people or people with quite a severe challenge. The thing is that because some of those pathways are changed and altered, and some of those parts of the brain are changed and altered, that recognition for the individual can be very, very changed. And we'll come to that just in the last line of this slide, very much more so. But actually, another thing that's been clearly shown in a variety of studies across particularly Europe, Australia, Canada, is that actually one of the major problems that if you've got a challenge, particularly with the communication and cerebral palsy, is our recognition of your pain. So there's been a real push on professional recognition, use of a variety of tools so that we can recognize those qualitative signs of pain, so that we can help individuals who are in pain who can't necessarily tell us they're in so. So overall, you have a whole variety of pain. We have pain that we all know about if you burn yourself or you scratch yourself or you cut yourself, your skin pains, those are pathways. You have a variety of pain receptors and different type of pain receptors associated with tightness, fatigue, and muscle pain. And you also have a variety of deep body pain, or what we call visceral or inflammatory pains. So there is a whole host of different types of pains. And it's just because you have one pain doesn't mean that you're not going to have any of the others. So there's a variety of pains that you can feel. And then the last type of pain is direct nerve pain, or what we call neurological pain. So as I stated before, when we're managing, when we're dealing with it, when we're thinking forward in the rest of the slides, it's really important for us to recognize that, yes, those physical sensory problems, but also there's that emotional and psychological element to pain and discomfort that we have to get on top of, that we have to manage as well. And when you've got abnormal pathways within your central nervous system, the challenge is that it can all change, it can all alter. So you can have basically what we call three things occur. One is sensitization, so that things that are very, very painful, if they're very, very painful the whole time, you don't recognize that they're there after a while, but they are constantly there, and they're constantly niggling and constantly causing problems. And sometimes only when those problems are removed can you then recognize that you're in pain and discomfort. The second one is if you have abnormal pathways, you can get a situation where you have something called hypersensitivity, so that actually you are incredibly sensitive to pain and painful stimulus. And the other side of that is what we call allodynia. So there's another big long word, but everything medical in this world is Latin at base. And allodynia means abnormal pain. And what allodynia means is that sometimes your pathways can be so mixed up that a sensation that for many people is pleasurable can be extremely painful. And conversely, something for most people, for the wider population, would be very, very painful, is actually quite pleasurable. So again, when we're managing, when we're helping, when we're supporting individuals with discomfort and pain, we have to have an awareness of the differences and challenges that you have with pain and pain pathways. Anything to say from when I look over here, Suze? It's because I can see you gloriously over there, so I'm looking at you. Is there anything else you wanted to say on this slide, or again, should we move on? Cool, that's great. So I am actually going to hand over to Suze now for the next few slides. Just tell me when you want me to move on the slide, Suze. But there we go.
Sure. So one of the questions this is something we often talk to many groups about is on this very topic, and how much of a problem this is. Last year I was talking at the Bobath Centre's study day nationally, and they asked me to come and talk about pain in children in cerebral palsy, but I actually changed the title of the talk to pain in cerebral palsy, because we know that this is not just an issue for children, this is adults as well. And both, as Charlie said, Charlie and I both see adults with CP also. So I asked some of the adults that I see to provide some statements so I could share with them, rather than me talking about it, to hear from them directly. Because when we talk about who is the professional about pain and cerebral palsy, well, actually, it's you, it's not us. And it's your voice that needs to be heard. And when people see you, it's you that they need to be listening to, and your families as well, I'm sure, to a degree. But we recognize that you are the one who knows what's going on with your body. You're the one who's experiencing that pain. So I asked some of the adults that I see to provide some statements about how pain has impacts onto their lives, and this is what they had to say. So the first statement is from a married couple who both have cerebral palsy, and these are their words that I'm using here. I haven't changed it at all. And what they said is, we were both born prematurely, so they were both born early, they had bleeds on the brain, and that resulted in a diagnosis of cerebral palsy. They're both paraplegic, and they use powered wheelchairs, and they're hoisted in and out of other equipment. Elle has, and I've taken out their names, sorry, because they gave permission to use these for our talks, but I'm kind of conscious of being kind of confidential as well about their identity. But Elle has very little use of his arms and hands, and he suffers with a lot of pain in his wrists, and he has severe sweating, in particular that's of his hands and feet. He had both of his ball joints and his hips removed in 2005, and he's had surgery on his tendons, and his adductors were operated on, so his muscles, as he was in intense pain. So he takes over the course of a day 150 milligrams of baclofen each day to reduce the spasticity in his body, and he has regular Botox injections that we see him for in his arms and to help with his hands as well. And sometimes he says the only way to stop the pain is to lie down in bed. And then I think the next slide is from B. And just to say, both of this married couple, they're both a very similar age, so they're in their early 30s. B has had several, we've gone back a bit.
Yeah, don't know what I'm there. There we are.
B has had several operations on her tendons and muscles as well to reduce spasticity. She also had a total hip reconstruction on the left, and she also had surgery to fuse her spine. She suffers with intense pain in her legs, for which she has Botox injections every 4 months, and these help considerably, and she says she couldn't do without these. She has spasms in her legs, back and buttocks, which are also very painful, and she needs painkillers as well as diazepam at times to help with this. And she's also on baclofen. They both say that the pain is considerably worse now as we get older. However, they enjoy their everyday lives, and they're lucky to have a good support system around them. The next statement is from A, and A's in her mid-20s. She has hemidystonia, and she actually found it really helpful, but I think it made her very reflective as well to put this together for me and to think about the impact that pain has on her life, which is very significant. So she has, she said, living with cerebral palsy and living with pain come hand in hand. Every day can be different. So from one day, she's able to, from walking around the shops one day to the next, barely being able to stagger to the toilet with muscle pain the next. Fidgeting, involuntary movements and balance issues are all embedded into her daily routine. And she has medication, injections, she has regular Botox injections, physiotherapy, orthotic support, and pain release gels help to ease the pain and discomfort. However, she can never fully escape from the dull ache and twitching of her muscles. Having dystonic pain controls her initially from being self-conscious when she's walking down the street, having anxiety when she meets new people, and having to constantly readjust herself to ease the discomfort, to feeling that life sometimes isn't worth living if all she feels is pain. And she says she has to take every day as it comes and hope that when I wake up, that the pain is less intense than the day before. So I think that it kind of speaks for itself, how much pain it can impact onto you. And sometimes it's not recognized that the problem that it is, you know, how big is the problem? And sometimes we don't realize how big a problem it is, but we, you know, the reality is it can be a massive issue when living with cerebral palsy. Moving on. And I think this is back to you, Charlie, is it?
Yeah, why not? I'll go. I'll do it. Well, you can start. Go on, Suze. You tell him about the constipation things and so on, and then I'll when it comes to our study, I'll take over.
Cool. So some of the causes of pain. Now, this is a funny slide. Sorry, I think you might have to click. Yeah, there we go. So there can be many different issues, and this list can keep going and keep going, but. Constipation, as we know, can be a big cause of pain. How severely your whole body is involved with cerebral palsy can impact onto the level of pain that you feel. Being static in postures, not moving contributes to that. Muscle fatigue as well as kind of joint pain and the musculoskeletal aspect. You know, the muscle weakness in itself can cause pain. The increased muscle tone, we've talked about spasms, and and you know, both spasticity and dystonia can really impact and be a big contributor to pain. Now, equipment and orthoses, it's something we'll come back to later, as well as therapy, that can also contribute to pain, and some studies have shown that physiotherapy itself can be a big contributor to pain as well, which is something that we need to reflect on, but we're going to talk about that a bit later. But obviously muscle contractures, the reflux, gastroesophageal reflux, and also the kind of also this impact onto our mood and lead to depression and anxiety when we're dealing with pain all the time. So there are many, many things that can contribute to pain. Moving on, Charlie.
Cool. So I'm just going to tell you that there are a couple of papers. One dealing with sort of adolescent and late teen and early 20-year-olds that was part of a large South Thames long-term South Thames study that we had published last year. And that gave us a very clear idea. It's a population that we've been looking from infancy right the way through, and now we're just about to revisit them into their late 20s now. But actually what we'd seen through all those ages and stages, that there was a definite increase in prevalence and the intensity of pain across that group over their 16 to 18 years. And really, the more motorly impaired, and again, I presume all of you have some that know about the gross motor functional classification system, or how much of a functional problem your gross motor challenge is, the more of a challenge you have, and the more your comorbidity or problems with your chest health and things like that, the worse your pain is. And one of the things that was very clearly linked to it was constipation. What we found is that in the population of around 300 young people that we have been following for a long period of time, is that into adolescence, one of the major factors that caused tremendous pain and discomfort, in particular, was period pain and the pains associated with that. And that's very under-recognized and very under-managed by the medical population as a whole. So that was a big factor that we were really stressing and putting forward, that actually support in women's health issues was a major factor that we needed to get on hold. And one thing that we've managed at St Thomas's subsequently is to get an adult gynecologist in a special interest with cerebral palsy. Hip pain, again, is very much associated with more functionally impaired, as is abdominal pain. And that's flipped back. Here we go. Most of the pain that we saw, however, was musculoskeletal. So it was associated, and it was predominantly in the hip region. Okay, but as I said, there are a variety of other factors that cause considerable pain and discomfort. What we were finding is that over 2/3 of our population group were having regular chronic pain, and very often, particularly in those with a communication challenge, it wasn't recognized by the clinical community. And so we need to make sure that it's really high up in our agenda when we're helping and supporting. What we also found is that with different levels of activities and different functional levels, pain occurred at different times. So individuals who couldn't walk easily reported their pain and discomfort musculoskeletally in their hips, etc., when they were being moved. Whereas those who could walk and were getting generally got the pain associated with fatigue when they were actively mobile. But again, that was just our population of 300 that we looked at very, very carefully. And so another thing in another group, Sue, is there anything else or on that slide? No. So do chip in. You know me, I'll talk until the cows come home. So if you're getting bored, you let me know. Just shut up, Charlie, and move on. This is something that I was also very much involved with as the clinical advisor to, and I still go on and help NICE, as Suze is now a scholar for NICE and working very much and very closely in that national setup as well, looking at transition, as Emma said at the beginning. But what we did is we looked at the challenges of cerebral palsy in adults. So we did the children's guideline back in 2017, back on the back of the children's spasticity guideline in 2012. But in 2019, we looked at the evidence base that there was out there on how we can help and support adults with cerebral palsy. And one of the major issues that we focused on was the recognition of pain, how much pain there was for individuals, and how we can help and support. And I would recommend you all, if you've never looked at it, to go onto that website. So it's nice.org.uk, go into the guidelines, look at the flow chart, and if you've got a clinical problem, it gives you very clear guidance on how the clinical community should be helping and supporting you. And it's an excellent tool, and it's an excellent tool not just for clinicians, but actually everyone with an individual condition as well. And one of the really clever things with the NICE guidelines is that, as you can say, this is NG 119. There are hundreds of NICE guidelines, and if there is any information from any other guideline that has been created by NICE, so again, if you're talking about period pain, say, there is a guideline on that, and it will give you the information and advice directly into, so you don't need to go hunting. You can click and get information on your challenges that you've got using the NICE guideline and the interactive tools that they've got on that. So it's a really good way of doing it. But one thing, I was asked to be a referee of this study that we've just put into publication in Developmental Medicine and Child Neurology, and should be out soon in print. It's on the back of CPIP, which Susie can give you infinitely more knowledge about. So hip surveillance, basically, in the child population in Sweden, which they've been doing very effectively for a very long period of time. And what they have done now is to move that into the adult population. So over 2015,
Can I just add, sorry, about CPIP, because it is really a patient management system. So it's looking at the whole person. So yes, it and hip surveillance, but also looking at them in entirety to see them as a whole, and then they moved into, as Charlie said, extending this lifelong rather than just focusing on children. So I think back in 2011 they extended it to looking after adults, and they survey them regularly as well, depending on their GMSCS levels. Sorry, Charlie, on you go.
No, great, Suze. That's, as I said, you know in your little finger everything I've got in my whole soul about CPIP. So it's fantastically helpful. So basically, this was a review and a reflection of looking at pain scores, looking at pain factors in over 1,500 adults with cerebral palsy across Sweden, and 2/3 of them reported chronic pain that strongly interfered with activities of work and sleep. So those who had pain were 6 times more likely to have a challenge with activities and work and sleep than those who were not in pain and discomfort. So as I said, 2/3 of the adults that across Sweden with cerebral palsy experience pain from more than one site. So on average, on median, it's 3 sites. So it can be back, hips, feet, or it can be stomach, women's pain, and back. I mean, but the numbers can go up into dozens. Okay. It is, as I stated before, from our study, and it's really good to see that they've gone into an older population right across adults with cerebral palsy and recognize that underreporting of pain in individuals who are challenged with communication efficiently. And it really relies on listening to the primary carers, listening to the primary supporters of individuals with severe cerebral palsy who are challenged with communication difficulties, because you know what, they know more. You know more about your own condition, but if you've got a close carer who knows you, they know more than any physiotherapist, any doctor, any clinician is ever going to know about the individual. So you must listen to the individual, and really what we're doing and what the call is from them as well is a real need to help the clinical community recognize that pain is such a serious problem in adults with cerebral palsy, and how to assess and treat that appropriately. And here you are, here's a whole variety, just the flip side of Susie's first slide, with a variety of things that can just make it worse. So not only have you got your clinical problems, but you also need to think about the environment in which we live. So when we're managing it, the environment is really important. And from my viewpoint, sleep and nutrition, they're almost there in your core factors. If you've got a problem with sleep, you know your pain's always going to be worse. If you're feeling hungry, your pain's always going to feel worse. So really some simple things before you start thinking about any specific treatments are really, really important to try and minimize the impact of pain. So concentrate on the environment that we all are in. Concentrate on trying to get a decent sleep. Trying to concentrate on getting adequate nutrition on board. So I'll hand back to Susie because my throat's going a little bit dry. So there you go. Oh, I'll do this one, Susie. I'll do this one, then you take over. Yeah, okay.
We're on a roll.
Yeah. Yeah. So really, as we stated at the beginning, the major factor that with pain with cerebral palsy is actually to do with changes of your muscle tone, changes within the musculoskeletal system. And we are very aware that over time, very good evidence looking at it that's set out within the NICE guidelines, the sort of things, the changes that happen with age, another big long word, the physiological alteration of what goes on with muscles, how much more difficult they are to contract, how much more tissue that doesn't stretch terribly well is laid down within your muscles. So you have this real challenge in your function, challenge with balance, challenge with maintaining your mobility that puts a real strain on the system, that puts a real strain on bones, that puts a real strain on joints. But as we said, anything that we focus on tightness, there is the flip side from a neurological viewpoint on fatigue and weakness, and they're really, really important. Over time, we know that from dealing with paediatric patients that Susan and I do almost on a daily basis, you get real changes in terms of muscle contracture formation. And when you've got anything that takes you out of a straight line position, it makes things a lot more difficult and it makes things a lot more uncomfortable. So joint and bone deformity are a real challenge when it comes to pain and discomfort. And right across the studies internationally over the years, the most challenged areas with regards to joint and bone deformity and pain are the back and legs. The other thing that we looked at very carefully within the NICE guidelines is the impact of low bone density when you're not weight bearing as much, and looking at the risk of osteoarthritis in cerebral palsy, which is a risk, but actually probably isn't as great a risk as we thought it was even a decade ago. So yes, there is, and we are always worried about arthritic changes in joints, but it's less of a problem than we actually were if you look at the studies over a long period of time, and it's really more of the musculoskeletal challenges. So again, when we're thinking about management, we've got to think about of our musculoskeletal pain in particular. You've got to think about how we can manage that muscle overactivity, whether that's tight muscles or muscles that are difficult to be controlled and dystonic. But don't forget the problems, don't forget the pain that's associated with muscle tiredness and weakness, because that's a big factor in its own right as well. Another minion for you, I think, Suze. Oh no, hey, we've gone back. Oh, you flipped through that one. Sorry about that. Let me
so
go
we're going
back.
to come on to think about how we can reduce pain. Thanks for the minion. Thanks. Sorry, we like to be quite silly. Yeah, so there are a lot of medicines that can be helpful, but we appreciate they don't help everybody, and they don't work the same as they do, you know, with one person as they do in the next. But some of the medications we would consider to help reduce spasticity, which can help pain, would be something like baclofen, and it works as a muscle relaxant, and that can be really helpful, especially if you have muscle cramps. and your muscles are just generally really stiff, but you have cramps as well. But there are side effects to medications, and that has to be considered as well. And we always find it surprising when we meet young people or families who are not aware of the side effects the medications can cause in itself. So baclofen can cause constipation, for example. So it's really important to be aware of that. And then you may need to take some medications to help with the constipation in order that you can then use the baclofen to help with your spasticity. It can also make you, especially in adults, you tend to need to be on a much larger dose of baclofen than we would use in children in order for it to be effective. And a side effect can be, it can make you a bit, it can make you sleepy during the day, and we don't want that. So sometimes we would prescribe and encourage people to take it at nighttime instead, because we don't mind if you're a bit sleepy at nighttime. Maybe that'll help you get a better night's rest. And often you can actually notice, some people will say they feel more comfortable still the next morning. Another medication would be diazepam, again as a muscle relaxant, and we tend to use that more to treat really acute pain when you need to break the cycle. Especially if things are getting worse, then you can get into a vicious cycle where pain will increase your spasticity more, and in itself that causes more pain, and that'll drive your spasticity more, and it just goes round and round and round. You can't break the cycle. So diazepam can be really helpful in that kind of acute time to break that cycle, but it's not something we would be encouraging you to be taking on a regular basis. And then we have botulinum toxin injections, which can be really, really helpful to treat pain. And they can obviously be really targeted because we can specifically inject the muscles that we think are causing kind of the biggest issues. And that can be really helpful. For example, if your hips are really painful, then we can target big muscles around the hip, which can have a real pain relieving aspect. Sometimes in a lot of the adults, we'll inject muscles down your back, because as we know, spinal pain is a massive issue as well, and that can also be really, really helpful at reducing pain. We'll do injections to your neck, pretty much anywhere, won't we, Charlie? If it's causing a problem, then we will at least try it and help. But it's also really important to think that sometimes reflux, as we've talked about, can be a big driver of pain and discomfort, and also laxative. So if you're constipated, medication to treat those can be really beneficial. And sometimes we would say, rather than giving a medication to treat the spasticity, actually maybe it is the constipation that's driving an increase in spasticity or dystonia that's then causing pain. So actually the best medication to treat the dystonia or spasticity might be something to treat the constipation or to treat your reflux. And sometimes, so I think it's empowering you, we spend a lot of our time trying to educate other health professionals that when they see individuals with cerebral palsy, to think outside the box, and we have to work out what's driving the pain. Why is suddenly your dystonia or your spasticity worse? What's going on in the background that's driving it? And is there something else that we can do to help as well? Charlie's already talked a little bit about sleep, and we can never underestimate how important sleep is. Because that's where we have the chance to kind of rest, repair, and then we can deal with whatever we've got on the next day. And if you don't get a good night's sleep, then that will impact massively onto your next day. That will make your pain worse, and then again, it's a vicious cycle. So it's so important to make sure that you're comfortable in order to get a good night's sleep. And again, it's about the emotional aspect of it, that getting the help that you need, being able to talk to people as well, can also be hugely helpful, and the environmental factors as well. I'm going to pass back to Charlie, because I can see he's itching to
I'm gonna rapidly zip you through the rest of this. So from a medical thing, again, I just cannot reiterate strongly enough, and what drives me and Susie nuts more than anything else is seeing an individual who we've been referred up with pain and discomfort, particularly if they've got communication challenges, and nobody's thought about where the pain is coming from, and all they've started giving them is paracetamol and ibuprofen, and they've moved up this what we call analgesic ladder that doctors talk about. So you move from quite mild pain medications to very strong pain medications, very often all the way up to morphine, and it's made no difference because actually they've not thought about the cause. So, but we can, if you've considered the cause, sometimes some simple pain relieving agents can be very, very helpful, particularly for that peripheral sensory challenges. If, however, you've got nerve pains, which is some of the major problems that you see with cerebral palsy, so some of the problems associated with spinal discomfort that shoots down your leg, or nerve pains in your legs, again, those shooting sharp pains, you then need to think about things that can damp down those working in the central nervous system. And there's a number of medications such as gabapentin and pregabalin that are very useful with that. But we tend to start with a quite an old-fashioned, what we call neurogenic pain relieving agent called amitriptyline, because it's very good at reducing anxiety. And if you've got nerve pains, it doesn't matter whether you've got cerebral palsy or you ain't got cerebral palsy. If you've got pain that is causing nerve pain, you're going to be anxious as well. And amitriptyline is really good at being a double whammy of reducing your anxiety and helping you with neurogenic pain, and actually has a far less side effect profile than pregabalin and gabapentin. So on to Suze. You got 2 more slides, guys, just so you're aware. We will zip through these, Miriam, I promise, but I'm sure we can hang on in here for an extra 10-15 minutes. It's not a problem.
Yeah, just very quickly, I think the key thing as a physiotherapist or as a therapist that we really advocate is that any equipment that you have should be comfortable as the first port of call. That's the most important thing, so is your wheelchair comfortable? If you have any, if you use a walker, it's less likely that maybe you're still using a standing frame, but if you are, is it comfortable? Orthotics as well, it's so important to ensure that. And what we would say, if it's not comfortable, can it be adapted to fit you? Let's stop asking people to adapt, like for you to adapt yourself to fit a wheelchair. These things need to be adapted. Specialists need to be able to look at you and the piece of equipment and adapt the equipment to fit you so that you are comfortable. And it's also thinking about function. We would advocate, use splints, for example, like ankle splints, if they help you to do something you want to do and you want to be doing. Otherwise, there's no point in having them on just to keep your feet warm or whatever other reason they've given you for wearing them. We know that the evidence is lacking that they maintain or increase muscle length. So we try to think outside the box, and it's so important. And it's the same with kind of positioning and with stretches. Stretches primarily can be very uncomfortable. So they can be good if you've got crampy, sore muscles to relieve that. But let's not use stretches and take you to the end of your available range to stretch your muscle and cause you pain unnecessarily. So that's just some brief thoughts from therapy, and I think we're almost done.
Yeah, we just really to lob in other treatments and say that we are very holistic. We think about the whole thing. We think about, as we stated, I cannot stress enough that this is the core of your psychological and physical well-being for all of us on the planet, and that really the things that feed into the challenges from a psychology viewpoint. So actually a lot of very good treatment programs are based on cognitive behavioral therapy and mindfulness techniques, but also the support networks we all have are key and critical, let alone the nutrition and sleep. There are a variety of alternative therapies out there that can be useful. I've seen a lot of young people who do very well with acupuncture, osteopathy, homeopathy, and massage therapies. And we, Susie and I, were involved in the international trial we led up on the one looking at cannabinoids in individuals with cerebral palsy. We hoped that it would be very useful, but actually it didn't show a clear evidence base with regards to spasticity and pain. But many of the young people that we look after, many of the old people that we look after, are very clear that a little bit of judicious cannabinoid use actually very good for their pain and discomfort, as many of the young people, particularly with dystonia, say that a little bit of alcohol, not too much alcohol, is also quite good at helping them relax, at reducing their anxiety and making them more comfortable. So really, I think, Suze, that's a lot for our slides. So we're here, we're online. Ask away, Miriam, if you're going to.
Okay. Well, throughout that fantastic talk you both gave, the chat, I don't know if you've seen it, but it's been very, very busy. So I've tried to group them, but there are a lot of questions that were posed. So if I start with the first ones, which are around pain and fatigue. Can everyone hear me okay? Yeah. Okay. So they're linked with the facts around the GPs are not that comfortable giving pain medication for too long. They don't necessarily understand the concept of fatigue, and how can we support our GPs to educate them in what our needs are for this community. And finally, when I want a referral for my pain, who should I be asking them to refer me to? Is it the pain specialist, the orthopaedics, the neurologist? Hand it over to you two.
I'll take the last bit and then I'll hand over to Suze and then I'll come back. So from my viewpoint, if you've got a regional network, and again, Susie may well give you a far better idea of where, because she's working really closely with her, but if you've got a network sorted out, then an expert who's got a level of knowledge in the world of adult cerebral palsy is fantastic. But we are all very aware that there is a big gap with regards to that, but we are pushing for it from a national perspective, from the paediatric world and into adults. However, I think you're probably going to get a better outcome. Please don't trust it. If you're married to an orthopaedic surgeon anywhere online, don't take this wrong, but don't go anywhere near an orthopaedic surgeon. Go and see a pain specialist. Ask your GP to refer you into a pain team. It's infinitely better, actually way more than seeing an orthopaedic surgeon. If you're going to have to go and see anyone who's a movement specialist, ask to see a physiotherapist.
Yeah, and I think just to add, we really recognise how difficult it is to be seen by the right person, the right team. And it's something that I'm at the beginning of a long journey of trying to sort out pathways which we recognise are needed for cerebral palsy specifically. So because it's a lifelong condition and we recognise that the services have for adults. So that's something we're trying really hard, and I'm pushing with NICE, looking initially at transition, but we are trying to build pathways.
He's quite famous.
His iPhone, can you switch off, please? Can you mute Samantha's iPhone? I think it's Samantha's iPhone. Can you mute Samantha's iPhone, please?
Is it?
Okay, is there anything else you wanted to add regarding the GPs and pain and fatigue?
No, I think if in your area you can ask if they have a consultant in adult rehab, or they have a therapy team that specialises in neurological conditions, then hopefully they have the right skills. But we know they may not necessarily understand cerebral palsy, but I think that the awareness is growing as well, and we're trying in children's services to work better with our adult colleagues so that it can be much more joined up working in the future.
Yeah, and obviously, you know, if you do have a neurologist who's got an area of expertise in this area, or you do have a rehab engineering team, then, or sorry, not rehab, but a rehab specialist, then that's fantastic. I would recommend you to ask your general practitioner, and or to petition your general practitioner about what the pathways of care are within your region. Another hat that I stick on my head is I'm head of children's neurosciences for NHS England, and I work very closely with my adult colleagues. And one of the main areas that we were talking about pre-lockdown was to try and ensure that neurology and rehabilitation in the adult world took cerebral palsy seriously. Because one of the reasons why I got involved with NHS England is that we need to think about high prevalent conditions. So we haven't sorted out, there's no point focusing on the minutiae if we haven't got epilepsy and cerebral palsy sorted out. Okay, I'm not really, and here I get really, I'm not worried about whether it's laser ablative technology or gamma irradiation knives for posterior hematomas. You know what? Because one person a year is going to have that. Whereas what I'm worried about are the 100,000 plus individuals with cerebral palsy in adulthood, because we're failing them at the moment, and we need to get a hold of that and grab hold of it.
Just for the stats, it's 130,000.
Yeah.
I was seeing Emma wanting to say it, but she's muted, so I. 130,000 adults. So,
yeah.
Okay, so the next area is under medication. So there's a few areas. This first is around Botox. How long does it last? Because someone had Botox and it lasted them 2 months. And is it painful when it's injected because someone's ex found it so painful they had to be sedated for it?
I think again, Susie will come in and whatever, because she has as much experience in this as I do, but I always prattle on first. Poor girl, I'm her cross to bear. But frankly, botulinum toxin physiologically works within your muscles to relax them for up to 3 months. The benefits can last longer than that, and we very often see if it's for a more functional issue, we tend to try and see them, the young people that we look after, once or twice a year, because we don't really want to overplay it. But if it's for pain and discomfort, very often we're seeing them for every 3 months. You don't do it any more often than 3 months. But what we're finding is that sometimes you're only going to get a couple of months worth of benefit, and then actually it starts creeping back over that month, and then we can get on top of it again for them. Suze.
And yes, I mean, sometimes it can be painful to actually do the injections, and that we would tend to use local anesthetic, so either like a cold spray or a cream that goes on to numb the skin before we do our injections. But obviously that is only numbing the skin, and we can't numb the muscle that the needle's actually going to go into. So yes, if your muscle, especially sometimes see if you're really your spasticity or dystonia is so switched on, then it can be really uncomfortable, but it's over very, very quickly, and it's short, and we tend to just do them under local anesthetic. I don't think any of the adults that we see, we don't do any of them under sedation or general anesthetic that you hear some people say. They
normally fall asleep when I start doing my Elvis impersonation on the whole.
Use distraction.
Still try and do Daddy Pig, but hey.
But it absolutely, it can be uncomfortable.
It is.
But normally people, once they feel really anxious the first time, but because if they find for them the Botox injections have been really helpful, then they're willing to come back and have it done again, because the injection itself is so quick to do, because they get the benefit for a few months afterwards.
Yeah, and we've had some young adults, haven't we, Suze, that really, you know, they've got that we've laced them with Bach's rescue remedy and brandy before they come and have their first time, and you can manage one injection the first time they come and see you, but then in 3 months' time they'll want 3 or 4, and then 6 months down the line, you know, they'll go just go for it because it's great. And yes, I know that this is a problem, and yes, it's going to be ouch, but actually, you know what? It's no more uncomfortable than having a flu jab. So just get on and do it, because I know it gives me 3 or 4 months relief.
Yeah, some of them come listening. Some of the adults we see listen to music on their headphones and things as a distraction, and don't watch.
Much better than me doing my Elvis impersonation.
Quite.
Oh.
So moving on to another drug, baclofen. Someone asked that it works for her spasms when she takes it, but it does make her quite wobbly and increase her risk of falling. So what might you suggest for that?
So one of the things that one of the ways that Susie sort of spoke about was do you sort of load your baclofen dose towards the end of the day? And one of the things that we found quite useful in the population group that we try and help and support is using almost sort of half the baclofen dose, sometimes even more, at night time, because its primary challenge is it does make you sleepy. And again, as Susie commented on, that if you're getting muscle tightness and spasms, you're just feeling more and more rubbish during the day, and then if you don't have a proper night's sleep, you're feeling more rubbish, and you're just going in a spiral down. And if you get a decent enough nighttime dose of baclofen, you can flip it back up, so you can cope. Though it gets more troublesome during the daytime, it's actually giving you one period of time, and you can flip it back up over a 24-hour period. So I would say 2 things. One is that if you're getting benefit from baclofen, I would load it more at nighttime, and I would maybe reduce your daytime doses when you want to be more awake. And the other thing that you should really be talking to your general practitioner and asking for a referral up is to consider an intrathecal baclofen pump if you've got long-term needs and long-term usage, when you won't need to think about taking medication. And actually it sounds fairly, whoa, they're putting a pump inside me, but really most of the individuals that we look after with intrathecal baclofen pumps forget they're there. They go underneath your tummy muscles. You know, the clinicians have got to use an ultrasound scan to find it when they have to refill it every sort of 6 months or so. And that can be really, really useful, because the problem with baclofen is it's a real challenge for it to get across what we call the blood-brain barrier. So it's really difficult for it to get to where it works, which is up and down the spine. So in order to get a drop of effect, you have to take a bucket's worth of medicine. Whereas if you can bypass all that with sticking an epidural needle that stays underneath your skin and goes all the way to a frontal, you can get 10 drops of effect with 10 drops of medicine, and your side effects are different. And you're going to have much less problem with sedation on the whole.
So just extending on from that with a question about the constipation, do you find that it gets worse over time, especially when you are on baclofen? Or does it depend on how you load it during the day?
Suze, I mean, Susan and I are one of the main, drooling, dribbling, saliva control and constipation are our daily, as movement disorder specialists, that's what we spend our life talking about. So is there anything you want to say, Suze, before I come in?
I think, you might disagree, but I think if baclofen is going to be an issue with constipation, I don't think it would suddenly happen if you've been on baclofen for a long time. I would think then something else was driving that.
I mean, simple things. We are huge fans of minimizing the number of medications because once you start going, you'll be treating something with another medicine for a problem that's a side effect of the medicine. And most of my world is one of driving individuals off medication rather than putting new medications in. It's pretty universal that any adult that I see in particular with cerebral palsy will be on way too much medication, and they are going to feel far, far better and less crappy the fewer medicines that they're on. Equally, there are certain medicines, such as when you're thinking about constipation, we tend to keep well away from lactulose, because both Susan and I have had it, and it's like turning on a beer factory in your gut. It's foul. And there are far better laxative medications than that out there.
Okay, so I'm going to move topics from specific medication and looking at a little bit more about different areas of the body. So one question is, why is cervical spinal stenosis not being screened for as a cause of pain, which seems to be under recognized in CP?
Yeah, no, I would entirely agree. So there is, I think, is one of the major challenges, and one thing that we highlighted within the NICE guidelines is real concern, particularly in dystonic individuals with cerebral palsy, is challenges at the cervical spinal level, so up in the neck, and challenges up there, and I, you know, those of us who see a lot of individuals with cerebral palsy, it certainly don't underplay it, and our spinal team. Colleagues certainly don't underplay it, and our neurosurgical colleagues certainly don't underplay it, but it is a message that is very difficult to get out there. I think some rehabilitation specialists, certainly adult neurologists, will have an awareness of it, but it is a big problem, and it's a big problem, in particular if you've got a dystonic movement disorder, rather than background pure high muscle tone. Would you agree, Suze? Is there anything else? Because you worked in the spinal service as well. She's far more interesting.
Yeah, no, and I think I would say that the spinal consultants I worked with at Evalina, they see children and adults, and they would take that very, very seriously and do thorough investigations to see somebody to determine what the cause of their pain is, if they have any spinal pain, whether that's neck or lower down.
And change in function as well. We've had several young people, very, very young, so even in their early teens, who've had change in function. You should not be having change in function. You know, if there is anything that you think, you need to investigate it. So we've done MRIs of the spine and in the cervical level, and found all sorts of challenges. So it's something that is very, very high in our thought process when we see individuals with CP.
Okay, so then moving on to another area, and someone has asked, should you treat pain in multiple locations that are potentially causing each other's discomfort? So we're thinking about a foot or a knee, or is it better to treat them individually? And another person asked about facet joint syndrome. So going back to your suggestion as to who to refer to, is that the case where you would think maybe we need to get the orthopods involved, or would you still go to the pain specialist or the neurophysio?
I would start with the personally, as a doctor, I'd keep everyone away from doctors. So I would start with a neurophysio, okay, who's going to give you a far better idea of what and where and the challenges. I see an awful lot of problems associated with facet joint abnormalities and vertebral abnormalities that are made far, far worse by orthopaedic or spinal input. So if you've got a really highly skilled individual, you know, local corticosteroid injections are fantastic, but to give you all willy-nilly who looks after motorcycle accidents and little old ladies' hips free range in a facet joint abnormality, that ain't a good idea. So again, I would be using a neurophysiotherapist as a point of highly skilled recognition of the challenges, who can then refer you on for the right person within your own network to get intervention if that's necessary. Suze, do you agree? Or
I totally agree. Well said.
So I think that brings on to a couple of questions around intervention and treatment. One wanted your thoughts around less pain equals less need for surgery and more effective rehab and sustained mobility independence. Is there an argument for either self-referral or specifically asking the GP refer you to a neurophysio? However, half the problem with that some people have mentioned is you only get 6 sessions and printed off with a sheet.
yeah, no, we are very cognizant of that as well. I mean, that is the real, that's the bug. That's why Susie and I carry on seeing individuals up to the age of 86, because actually it's a real challenge that the way that adult difficulties are managed is very set up on specific pathways and does not think about chronic conditions. So actually very often rehabilitation teams are very useful because they're slightly more long-term. But Suze, again, has far more knowledge about such things than me. So
yeah, I think there is a real challenge, because it's you want to be seen by an individual who understands cerebral palsy and how it can affect all of you. So not just thinking about, you know, your hips or your neck, but also, you know, can understand, you know, all the medications that you're on, and the side effects of those, and all the issues or all the potential problems that may be causing you pain, because they can be related. But I appreciate we don't have the answers that you necessarily want to hear, because the pathways to support you with cerebral palsy in adult services aren't there yet. But you know, we are trying to push that and work on that.
So
from a, you know, if the reason that sort of multifactorial, multi-area challenge you were talking about, Miriam, is that if you've got a contraction, say at the ankle, that is going to send you out biomechanically at the knee level, which will then send you out biomechanically at the hip level, all of which will cause pain all the way up the system. Well, then, you know, if it's asymmetrical, it'll then cause pain and discomfort so it is pointless thinking about an individual joint or an individual muscle group. What you need to do is you need to think about the whole person. And yes, though we use targeted botulinum toxin injections, it's rare that we do, unless you've got very severe dystonic spasming in one muscle. You've got to try and think about where the balance. Are you trying to improve things biomechanically by relaxing out particular muscle groups and reducing the spasms?
So there was some questions around the mental health side of aspects, because someone said that they asked how to manage their pain caused by mental health and how it impacts on their CP. And I think also there was a question around how we can help the GPs advise with you talked about amitriptyline and gabapentin. And I think that's one of the things a lot of people are feeling, that their GPs just don't have the equipment or the knowledge, and that how can we advise them? So
I would go on to nice.org.uk or whatever it is, and I would look at the flow pathway of management of cerebral palsy. I would look at the clinical conditions that were looked at carefully. It is it is guidance for medical practitioners at the first point. And so if you can go four-armed and say, actually, I think what you'll find in the NICE guidelines is X, Y, and Z, you are helping your GP. And why don't we if you've got, doctors are funny creatures. We're odd, but I think we've moved, when I was training back in the 1980s, it really was a God complex in terms of I'm the expert, don't argue with me. As a doctor, whereas I think there is a generalized recognition now that actually you are experts in your own problems and challenges, and we're here as advocates as much as anything to help you through the pathways that we can do and should do, and to try and give trials of medication. Obviously different if you've got diabetes, obviously different if you've got epilepsy, in which case, but you are experts in your own body, and we are here to help and guide in whatever form and fashion that we can do, rather than being just don't argue with me, I'm the expert. It shouldn't be working like that. Once you started getting into neurogenic pain, fundamentally from my perspective, you should be seeing a pain specialist team. That shouldn't be something that would routinely be managed by your general practitioner. Equally with mental health issues, I think the real challenge, and we're talking about a lack of clinical expertise in the adult cerebral palsy world from a doctor's viewpoint, it is just a desert of tumbleweed when it comes to mental health. So I've got another 11 and a half years, and Susie knows this only too well. So I've spent the last 20 years getting pain on the agenda. My next 11 and a half years are focused on getting mental health issues and mental health support sorted out for individuals with challenges, physical challenge, because we are absolutely pants at helping support individuals with the services that we provide. And that's not just the UK, that's internationally as well.
So another specific question before we move on to the sort of final, more general question is, do you have an alternative to amitriptyline for those taking medication who have epilepsy as well?
Well, I think if you're looking at neuropathic pain in particular, and you've got epilepsy, you then need to really, you do need to consider the gabapentins and the pregabalins, which are in their own right anticonvulsant medications. Lamotrigine is very good. Levetiracetam, a number of anticonvulsants are actually very, very good in neurogenic pain in their own right. I tend to use levetiracetam. I've got some colleagues that use topiramate an awful lot. So there is a variety. The problem is that it's very individual, because we're a chemical soup, and trying to get that chemical soup right for an individual. Some people need a pinch of salt, some people like a little bit of vinegar, some people it's some pepper, and it's exactly the same, because all those anticonvulsants are trying to reorganize and restructure your chemical soup as it's going on. So getting the right one is very often a requirement of trying therapeutic trials. Give it a go, see if it helps. If it doesn't, don't carry on. There's no point saying, the worst that I've ever come across was an individual who was on 16 anticonvulsants. Once you're on more than 2, you shouldn't be. Okay, 16, the side effect profile is just shocking. So don't accept being put on numerous anticonvulsants, whether it's for pain or whether it's for epilepsy. 2, maximum 3 is tops, plus a benzodiazepine, a diazepam, or a midazolam. Is there anything from because you see this as often as I do, Susie, was there anything else? I know I've given a bit of a medical spiel there, but is there anything else?
I just think it's when you're taking that many medications, if it's not helping, it's about trying to get a referral to see somebody else who can look at, listen to you and look at you with different eyes. Yep. Because it's not working. And as Charlie says, adding in more medication isn't necessarily going to help, because you're just adding the side effects as well. And that could be making things worse in the background.
And a lot of them have very, very strong psychological, very, very strong problematical with your mental health side effects. So it's, again, because we are actually quite a simple chemical soup, and movement disorder medications really can interfere negatively with how you feel.
Okay, and finally, it is a more general thing, but where do you feel cerebral palsy ends and post-impairment syndrome begins? Any advice on diagnosis, communicating and explaining these to the services? Because aging and disability isn't something they seem to understand.
Yeah, I think post-impairment syndrome, I think, again, those of us who deal with adults with cerebral palsy would say that is just part and parcel. It is part and parcel of it. It is not, I don't think one starts and one finishes. It's just part of cerebral palsy, as hip disorders can be part of cerebral palsy, as is, we are very aware with aging, all those factors that we're talking about from a musculoskeletal viewpoint lead into that consideration of a post-impairment syndrome. It's some individuals it comes very, very early. Some individuals it's in their 60s, 70s. As it is with a much wider population, because actually post-impairment syndrome very often is seen in the much wider population, but slightly later. Susie, is there anything else you wanted to say with regards to that or not?
No, that's good. No.
Okay, someone just reminded me about a question that they actually emailed and I've forgotten to ask, so I do apologise.
Oh, Miriam.
I know, it's terrible. Okay, I'm just trying to find it because it was number 1. Okay.
Number one.
Pain management. A pain management physio once said I should move the pain from the sympathetic nervous system to the parasympathetic nervous system. How do I do this?
I generally find that if you go out on a cold, starry night, okay, point towards Jerusalem, and rub worms across your forehead. That's I'm afraid is a relatively, there is absolutely with the greatest respect to that individual, because I'm sure they had a clear idea of what they thought, but there is no real clear idea behind, and I'm very glad that you're shaking your head as well, Miriam. There is, yes, the parasympathetic nervous system and the sympathetic nervous system are very, very important, and they're the basis of what we call the autonomic, or the nervous system that we don't think about, but actually moving from the parasympathetic to the sympathetic, because it's the nervous system that you don't think about, A, is virtually impossible, but B, doesn't make any sense when you're talking about pain anyway, because that's not part of the autonomic nervous system.
There are a number of different questions that are coming in still, but I think that as it is 8:20, we're going to have to wrap it up. I hope that we've answered as many broad areas as possible. Thank you for your questions, and if you want to keep them coming, then we can see what we can
feed them in. You can feed them in. Yeah, go on, whatever.
But out of this evening's chat. But I'm going to hand over to Emma now for the close. But thank you everyone for your contributions.
It just leaves me to say thank you very much. And like Charlie, I always talk about wearing many hats. So I sat here this evening listening as someone who's running a charity, but also somebody living in pain with cerebral palsy. So what it made me realise, once again, how wonderful it is to speak to someone that really does, or two people that really do understand. And reading on the chats, the conversations, it really is clear that that's what adults with cerebral palsy need, and that's what we'll continue to fight for. I think Charlie has underlined why we established Adult Cerebral Palsy Hub. So thank you very much, Charlie, for all your support, and to you, Susie. If anybody has trouble finding any of those guidelines or any of that advice that you're going to take with you to your GP, that is one of the reasons that we set our website up, so that you can go and be an advocate for yourself. And also Miriam and I are here on a daily basis to answer any questions and to point you in the directions that we know, and we know that we're still building up that network. So, but we are here to help you. And lastly, apart from saying thank you for your time, I'd like to say, if you have enjoyed this evening and you think you'd benefit from hearing from other professionals that perhaps we can get to come to another one of these sessions, please do email us. We'll try and get some different people to come and talk to you, because we know how difficult it is to access the professionals that you want to talk to. And again, crudely, we are a charity, and we're working to change things, but we are doing it on a shoestring. So if you've really benefited from tonight, like I have, and you feel able to make a donation, please go to the website and to our crowdfunding page, because we are trying to raise some money so we can extend the services that we can offer as a charity. So thank you very much. Thank you, and we will feed any questions into Susie and Dr Fairhurst if we can. Oh, and I promise, because this has been an issue before, we will have this up on YouTube by tomorrow evening. So if anybody didn't come and wasn't able to hear all of the information, or indeed wants to go back and listen again, I certainly will be, then it will be there by tomorrow evening. So thank you very much. And good night, everybody.
Have a good week, everyone.
Thank you.
Thank you,
Bye,
Charlie. Thank you.
Bye, everyone.